Good evening. We're going to get started on time to respect your prompt attendance. We'll let late arrivals straggle in. I'm Bill Brown with Brookings Mountain West. Thanks for joining us on such a glorious day. And with the, for those of you who aren't from the university, with the onset of spring break happening as of the end of classes on Friday, you may notice a few less bodies trafficking around campus. Especially pleased to have a couple of our new colleagues from the UNLV School of Medicine here. So, Ross, you better be on your A game, okay? Let me introduce our speaker and get out of the way. We're really excited to have Ross Hammond back out. This is Ross's second trip out here as a scholar, but he's no stranger to the West, and he's getting to know a little more about Las Vegas as he spends time here, gets in the classroom, and talks to faculty and others. As you can see from the screen behind me, he's director of the Center on Social Dynamics and Policy and a senior fellow at Brookings. Also has academic affiliations, as so many of our Brookings colleagues do. And he's going to present a fascinating talk tonight with his unique background to bring a systems approach to a public health issue. And he's going to have a lot of data and information for you. Don't panic. As regulars know, we record our lectures and they'll be up on our website in a few days. So if you want to refer to any chart or words of wisdom that Ross has, he'll be there for you. So Ross, I'll turn it over to you.
Thank you very much. Thanks for inviting me. There won't be a quiz on the way out, so I don't feel that you have to memorize things. I'm going to be covering a lot of terrain relatively quickly to give you a broad, sweeping overview of this idea of a systems approach to preventing chronic disease. And on the way, I'm going to show why I believe that the community level or the city level is a particularly promising focus for interventions of this type, and indeed a lot of my work is in that space right now. And I'll also talk about some new types of computational research, computational modeling that are going on in the broader public health research orbit that are very relevant and that are being applied in this specific topic space, and I'll show you some examples of those. I'm primarily going to be using obesity as an example, as a vehicle to communicate ideas, but what I'm saying actually applies in most cases much more broadly to chronic disease prevention, and I will indeed show some examples from things like tobacco control as well. I'm going to start by talking, just for those of you who don't have this background, about the context, the scale of the obesity epidemic, the trends, the local incidents here in Nevada, and then to sort of illustrate the complexity of problem that obesity represents, and talk about what challenges that produces for effective policy in this space. Then I'll introduce this idea of a systems approach and talk about why I think this can help us manage this kind of complexity. I'll talk about the importance of the community as a place to intervene, and I'll show you some examples of new work I'm doing right now that's about the application of complex systems models at the community level to obesity prevention and to tobacco control. And then I'll leave time at the end for questions and discussion, hopefully 15 minutes or so, so hold your questions till then if you wouldn't mind. For those of you who don't know, we have a crisis here in the United States. It's actually a global crisis now with obesity. The percentage of obese Americans has more than doubled since 1970. We're now in a situation where the majority, 2 in 3, American adults are overweight, and 1 in 3 are obese. And this chart here will show you the fairly alarming rise in overweight and obesity among adults from 1962 here to about 2010. And you can see that there's been a dramatic increase during that time. And this is actually a nationwide trend. So in 1989, every single state in the United States had an obesity rate lower than 15%. And by 2010, the lowest obesity rate in the country was 21%, and it was in Colorado, and that was a bit of an outlier, with most states having much higher obesity rates. So this is not restricted to any one particular place in the US. Here are some maps from the CDC, which show the incidence of obesity by state, and you can see how different the map looks in 1990 and in 2010. So this is a fairly recent but quite dramatic increase. Here's the latest data, if you're interested, on adult obesity rates by state. And you can see this color coding Yellow is less than 25%, beige is between 25 and 30%, orange between 30 and 35%, and red above 35%. And you'll see both that there's variation around the country, but that everyone really has this problem. And the variation becomes more pronounced, actually, if you go to the county level. You can see that within states, there's actually quite extreme variation among the counties. So even though this is a nationwide problem, there is actually quite a bit of variation. There's also interesting variation by income level, gender, and race here in the United States. But this is no longer a problem that's restricted to any one particular group primarily. So this is not a problem that affects primarily the poor anymore. It affects most people in the United States. But there are these interesting interaction effects between, for example, race, gender, and income, which are shown on this chart, which is very busy, so you probably won't absorb all of this. But there is quite a lot that's interesting and subtle here to draw out. This is also a major epidemic in children here in the United States. It was recently estimated that 1 in every 3 children born in the United States today will be diabetic in their lifetime. Many of these people will develop diabetes very early in life and have a condition they have to manage for the rest of their lives. And as a result, children today in the United States for the first time in about 100 years may actually have a shorter life expectancy than their parents. And may, in addition to leading shorter lives, lead much less healthy and sort of productive lives in many cases, which is a real problem for our country. Here's a graph showing childhood obesity prevalence from 1960 to 2008, and you can see quite alarming increases in all 3 age groups shown, 2 to 5 years, 6 to 11 years, and 12 to 19 years. And because we know that once obesity is in place, there are a variety of reasons why it's very hard to reverse. Not impossible, but hard, which makes prevention really important, and which means that since most overweight and obese children go on to be overweight and obese adults, that this alarming rise in children portends a continued rise in adults well into the future, even if we address the problem now. And so I have some data on that on this slide. And finally, the thing to know is that we're not alone here in the US. We have a particularly bad problem with obesity, but in fact, this is a global problem with about 2 billion people overweight and obese in the world, which is similar to the number who are nutrient deficient by some estimates. And actually, 2 out of 3 of the overweight in the world now live in developing countries, not in the wealthy world. So here, if you are interested, is a nice little animation which shows, let me make it a little bigger for you, which shows BMI, body mass index, which is how obesity is measured, for different countries in the world, for women and for men. And each of these dots is a different country, and they're color-coded by the region of the world they're in. But you can see that almost all the dots are moving that way, up. And so this is hardly a problem which is restricted only to the United States. And if I close this for you for a second, I will show you a map that represents the current best data from Lancet 2013 of what global obesity rates are. And you can see lots of variation around the world, but very high rates in much of the world. These are rates for men, adults, and for women. And so what's happening here in Nevada? Well, in 2012, obesity prevalence here in Nevada was 26.2%, which is the 12th lowest in the US. So like I said before, no one is doing particularly well in the US, but Nevada is doing better than many. Childhood obesity rate about 20%. Diabetes rate about 9.6%. Las Vegas itself, as a metropolitan area, has about 37% of adults overweight and about 23% obese. So those are the latest data. So it's certainly a problem here, although not as much of a problem as some other parts of the country. There's also quite a bit of variation by county. So these are obesity rates by county here in Nevada from the county health rankings. And you can see the variation that's going on here. And this is, interestingly, you think for a second about where obesity comes from, this is the percent reporting any physical activity at all in men and women by county from 2011, and you can see there are quite a few differences across counties here in Nevada. And this is the percent of all restaurants that are fast food establishments in Nevada by county. So eating, physical activity, both important drivers of obesity. And you'll see, again, variation with lots of very high numbers, like 57, 58% of all eating establishments being fast food in 2015. So why do we care about all these high rates of obesity? Well, first and foremost, there are serious health consequences associated with being overweight and obese. Much higher rates of coronary heart disease. Being overweight makes you 50% more likely to develop coronary heart disease, and by some estimates, being obese makes you 2 to 3 more times more likely to develop coronary heart disease. You're also at higher risk for many other things, including diabetes, hypertension, high blood pressure, many kinds of cancer, arthritis, asthma, etc. Note that many of these are chronic conditions that incur lots of poor health over long periods of time. And because of that, in part, there's also a serious economic impact associated with these high obesity rates. Economic costs associated with obesity in the US, many varying estimates. They could be in total as high as about $210 billion a year, which is a big number. Obesity attributable medical spending, that is medical spending incurred by overweight and obese in excess of normal medical spending, is now accounting by some estimates for over 20% of all our healthcare costs. That's a number which has doubled in the last decade, which could easily double again in the next decade if we don't get this under control. And there are many other costs besides medical spending costs that I don't have time to go into, but I'm happy to during questions if you're interested. And like I said earlier, not only are our children becoming overweight and obese at younger ages, but they are therefore having onset of obesity-related health problems at much younger ages and incurring costs much earlier in life over longer periods of time. And there even are some studies which suggest there's an educational effect associated with school-age obesity, not a good one. And you can see in this graph here, which is a little hard to read, but I will walk you through it for a second. Each of the points on the x-axis is a birth cohort. So these are people who were born between 1926 and 1935, et cetera. And on the y-axis, what we're seeing is what age decade it took for at least 20% of the birth cohort to be obese. So this is saying that people born between 1926 and 1935, it took until they were in their 50s for 20% of them to be overweight and obese. By contrast, people born between 1966 and 1985, 20% of them were obese by the time they were in their 20s. So that's a dramatically different number. Then that's what this graph is really showing. Okay, so why aren't we doing more about this if this is such a terrible problem? Well, and in some sense you might think, and it is certainly true, that from one perspective obesity is simple because it's about energy balance. And if you take more energy in than you expend, you will gain weight, right? And there's actually a very small set of behaviors that are the most important behaviors for driving obesity: eating, physical activity, sleep, possibly stress. And there are some clear opportunities to intervene. We can do things in our parks and recreation environments, in our food and beverage environments. We can do public health messaging. We can work in schools. We can work in primary care. But, and there's an important but, the behaviors themselves and the translation from the behaviors to the outcomes are actually very, very complex. And they're complex for a number of specific reasons. One of those is that they're affected by so many different levels of scale, all the way from biology through public policy and lots of levels in between which interact with each other. There are also many different actors involved in obesity, and they are very adaptive actors, as I'll show you in a second. Lots of diversity, lots of different pathways to the same outcome of obesity. And there are opportunities to become obese throughout the life course, and the reasons people become overweight and obese at different points in their life course are different in many cases. So let's see some examples of what I'm talking about. This is a result of an effort in the UK called the Foresight UK group to draw a picture of all the different things that matter in driving obesity as an outcome. And I've purposely made this too small for you to read all the details, but each one of these things is a factor that affects obesity. And the arrows show where there is evidence that factors affect each other. And so what you are seeing is that everything affects everything else, more or less. There's all kinds of interactions going on. So a lot of the conventional ways in which we study public health and many other topics is to try to isolate individual effects, to assume that there's independent effects of many individual things, and that won't work very well here because everything is actually interacting with each other. That's the first point. The second point that I said is that there are many different types of actors who affect obesity as an outcome. So some of them are obvious. You think about consumers, the food industry, retailers, the USDA, but other of them are less obvious. If you think about community coalitions and school principals and healthcare providers, these are really important actors for obesity as well. And each of these actors has different goals, different incentives, different constraints on their behavior. And if you intervene in a system like this, what you do will affect all of these different actors differently. And the connections between the actors and how they interact with each other is not entirely clear in many cases to you as a policymaker or researcher, and they're often not clear to the actors themselves. So they don't always understand the totality of impacts they have on the system. There's also lots of heterogeneity, lots of diversity across all of these categories. So not all school principals are the same, not all parents are the same, and those differences, which can be biological, psychological, cultural, those really matter. There's also lots of adaptation in the system. So what do I mean when I say that? I mean both that people are strategically adjusting their behavior given the context they're in to reach certain goals. That's behavioral adaptation. But there also is lots of biological adaptation going on in this system. As you gain and lose weight, your biochemistry actually changes. And those changes actually can make it harder or easier for you to gain or lose more weight in the future, and in ways that are really important part of the dynamics that are going on here. So adaptation. There's also lots of spatial patterns that are super important in obesity. So this is a map of average exposure to fast food across the 5 boroughs of New York City. It's like the heat map. And you can see that there's actually quite a bit of complexity here, and where you live might matter a lot, and where people travel through this space might matter a lot, and we're going to come back to that later. Similarly, our social environment can matter a lot. This is a very famous picture in public health circles that was published in the New England Journal of Medicine and then became the subject of media frenzy and TED Talks and all sorts of things about the idea that obesity might be contagious through social networks. So this is a picture of a social network in which each of these dots is an individual person and the lines are social relations between the people. And there's this particular work has been widely criticized and widely lauded by many different people, but I think there's growing evidence that our social environments matter a lot when it comes to obesity, and that getting the details of how that works right are important. And finally, time is really important for obesity, and things that happen to us early in life can matter in ways that only become clear much later in life. And those long time lags and long time dependencies make it a particularly challenging problem. So there's some implications of all this. The first is, in my view, that the search for a single cause of the obesity epidemic is probably misleading and misguided. I don't think there is a single cause. I think there are many causes, and our standard approach to studying problems, which often involves trying to isolate single causes, might lead us astray in some cases here because there's so many causes which are interdependent. The second implication is that trying to hold in your head everything that was on that spaghetti diagram is hard. It's hard. And so we need some kind of tool that can help us manage all of that. We can't keep it all in our head and just go by intuition. Intuition is not a good guide when systems are as complex as this. And third is that there is likely no single solution, no magic bullet that will work in every circumstance and context. And what we actually need, I think, and what we've learned that we need, are policy solutions that are both sufficiently broad that they can cover lots of people and lots of contexts, and sufficiently tailored that they can be the right solution for the right context at the right time. And that's, of course, really hard to do. There's also some evidence that we need to think about this as a system when we intervene, because if we intervene only in one place, what we do may simply be offset by what happens in response somewhere else. So for example, if we succeed after a lot of effort and expense in changing the food our children are served in the school cafeteria, but we don't take care of all the junk food that lies on the path they walk from school back to home, then all the good work to get them to eat vegetables in the school cafeteria may simply be offset by increased eating of junk food on the way home. That's one example. There are lots and lots of examples like that in obesity. So the most powerful interventions are likely those that simultaneously address both individual change and environmental change in a cohesive and well thought out way. And that's going to require some coordination across sectors of policy that don't necessarily like to work together, and tools that will help us understand how to do that effectively. So here's a quote from a National Academy of Science report on obesity prevention, which concluded that there is an urgent need to employ large-scale transformative approaches focused on multi-level both environmental and policy changes within an interconnected system to reduce the threat of obesity and sustain an enduring impact. Okay, how do we do that? That's where a lot of my research comes in. I think that for reasons which are hopefully now obvious, we need computers to help us do this. Okay, this is a nice little Far Side cartoon. And that brings us to the topic of a systems approach. So a lot of work has gone on recently from the National Academy of Sciences, the Institute of Medicine, countless scientific papers, lots of policy briefs that argue that what we need are a perspective and a set of tools that allow us to take this more systemic look at things like obesity. That looking at one thing at a time and looking for a magic bullet has been a mistake and has not led us to the kind of progress we would hope for. And so there's been a lot of investment by NIH and others in these new tools from a field called complexity science. And these are tools which have a strong track record in other areas, in the social sciences, in biology, in systems biology, for example, for cancer treatment. And there's a lot of potential for them to help us do what we need to do in the context of obesity prevention and tobacco control. So the first thing I want to just define is what is a systems approach. So a systems approach is both about understanding the broader context, understanding the interconnections that make this a system, but at the same time it's about being really attentive to the importance of context in particular situations and heterogeneity, diversity across all the population you're trying to address, and to try to focus on these interconnections as a good thing, as something you can leverage to help policy succeed, rather than as problems that will derail policies which are otherwise well-intentioned. There's a variety of ways to do that, and one important way that's emerged is a qualitative approach, which you saw a little bit of foreshadowing of earlier, called systems mapping. And what you do when you build a systems map is you try to just draw, to put in a visual context, all the existing structures, actors, activities, or intervention elements that are going on in a system, to organize them and to be able to identify in a qualitative way what some of the important connections actually are. And this is sometimes a participatory activity in which communities, which are deep repositories of knowledge about the world they inhabit, can actually see that knowledge and interact with it and contribute to the design of more effective policies. And so one of the most successful interventions, systems interventions to date for obesity prevention took place in Somerville, Massachusetts, where they did, in fact, some very nice mapping of the different spheres in which they were active in the intervention and how the actual things they were changing related to each other. And that enabled a more systemic approach to intervention. In that report I told you earlier, like all National Academies reports, it has a huge list of things they think should be done, okay? This is how all the National Academy of Sciences reports end, with a big list like this. But they went a step further in this report and actually drew a map of how the different actions relate to each other. And what you can see is that one of the criteria for picking the recommended actions it wasn't enough to say there's a lot of evidence that this will work or that will work, this other thing will work. There was a real attempt to think about a package of interventions that would work together, that would have reinforcing synergy, rather than being just sort of a scattershot approach of a million unconnected things. And there are some examples I will draw from this report, which has had a big impact since its publication. One of the kinds of linkages between policies is to think about something which is actually a prerequisite for something else to succeed. So if you think about menu and food labeling as a strategy to try to get people to eat healthier food, that is likely to require that you have already done something like nutrition education so that people actually understand what a calorie means, how many calories is okay to eat, and what all these complicated percent daily values are actually telling you and how to interpret that information. So those two things work well together. Similarly, if you invest in more park infrastructure so that people will get more physical activity, but you haven't done anything about deterrence to physical activity like crime, high crime rates, no transportation, no supervision of children, it's not clear anyone will actually use the new infrastructure. So there's a prerequisite that you have to consider so it's a package of policies. Another kind of relationship is filling in gaps or having reinforcement. So again, let's take investment in park or recreational infrastructure. If you couple that with actually making sure that the food options right near those parks are healthy ones so that when people finish exercising and they're hungry, what's right there for them to eat is healthy, you can have positive synergy between those two interventions. Similarly, if you are interested in advertising reform and you couple it with education to improve media literacy, then you can have much more powerful impact than either of those two can by themselves. And then there are some natural complements. So advertising reform can be coupled with investment in park and recreation infrastructure, which I alluded to earlier. Reducing barriers to physical activity can reduce screen time and thus exposure to advertising. So those things are actually natural complements. We're doing the same thing and working together to achieve the same goal. Similarly, increasing breastfeeding coupled with making healthy food widely available helps you to alleviate some of the potential consequences of shorter breastfeeding times by filling in a gap that would otherwise exist. And finally, you can, if you have a single goal, a single action you want to achieve, and you approach it from multiple dimensions at once, you have a better chance of actually changing something. So if your goal is to increase breastfeeding, and you do it by promoting through primary care consultation and changing social norms, and reducing poverty in teenage pregnancy, and supportive worksite policies, and baby-friendly hospitals, you probably achieve a lot more change than doing these things individually. So that's sort of the message of this report, which concludes with this nice graphic here that says there's all these different places to intervene, and if we do them in a coordinated way, we have much more impact, even multiplicative impact, far beyond just simply additive impact of doing all the things individually. And that's really important. So there's an opportunity to take what you might call a surround sound approach to policy in this space, to cover all of those bases that I showed you were important earlier in my talk. And the problem is that that's really hard to do. It's really hard to do for a number of reasons. One of the ones that looms the largest, particularly when we try to do this at the federal level, is that coordinating policy and action across all these different agencies and sectors is really hard. It is hard for both good and bad reasons for the FDA and the USDA to work together. There are lots of reasons that is hard. But that's what we're talking about here, is that kind of coordination. And for that reason, in part, the community level has emerged as a really great place to do these kinds of systems interventions. It's a high enough level of scale that you can make major environmental changes that affect lots of people through, for example, zoning policy or tax policy. But it's a low enough level of scale that you can actually think about a Department of Health coordinating with a Department of Transportation, which is kind of hard to think about at the federal level in the current climate. So that becomes a powerful reason why communities can really make a difference and can be the leaders in this space rather than sort of following behind some federal policy that's at work. But from a science perspective, we need to make sure we're going about this the right way. And interdisciplinary work is hard. And we know that the process of implementation, it can be make or break. So we know what levers to pull, but how to pull them is what we need to learn more about. And that's the focus of a lot of my work at the moment. And to do that, I use a set of tools, which are quantitative tools now, moving from the qualitative to the quantitative. They are computational tools for the reasons we talked about earlier. And what they really are virtual communities that we build here in our computers that allow us to think about systemically what kinds of forces are at work, to discover some currents that are going on that drive a lot of outcomes in real communities, and then to experiment with policies in a way that isn't destructive, costly, time-consuming, or unethical to do in the real world, that doesn't waste a lot of time, and that is very focused. Just like a biologist can do an experiment in their lab. We can do policy experiments in these sort of virtual worlds. Okay? And this is an approach that has been the focus of a lot of investment by NIH recently. And it started with work in infectious disease about 10 years ago. There was a sustained investment in this kind of modeling in the context of infectious disease, and it had a huge impact. So I belong for many years to a big NIH-funded network of modelers called MIDAS, which had lots of scientific and policy impact, lots of fancy publications, but more importantly, it received the HHS Health and Human Services Distinguished Service Award for contributions to making a real difference in public health in this country. And it did that in part by, during the H1N1 flu pandemic, by using models of this kind to allow policymakers to explore many different options and to anticipate unintended consequences that might come from those interventions. These are big, fancy models. They contain tons of data. Every flight taken everywhere in the world in many of these models, detailed depictions of sharing of patients and doctors across large hospital chains, detailed depictions of social networks, like that picture I showed you earlier for obesity, lots of sophisticated attention to individual behavior and getting an understanding of how people react to situations in the real world, and even a lot of biology goes into these models, and they can be very large, fancy models. So these are models which were developed at Brookings during the flu pandemic. They are simulating the spread of a flu pandemic in a virtual world, like I described earlier. This is the entire United States. 300 million individuals are represented and modeled. And here's a global model with several billion individuals. And these become policy laboratories where we can say, well, what if we closed the airports? And what if we closed the schools? And what if we sent the vaccine to Texas? And what would happen? And which of these options might be the best for us to consider? Models like that don't remove uncertainty or the need for judgment or difficult choices by policymakers, but they can help make those choices more informed. And these models can be very spatially accurate. So this is another model that we did around the same time that is a model of evacuation planning and crowd dynamics. So you are looking at a three-dimensional representation of Los Angeles, every building and every road in 3 dimensions. And these dots that are zipping along here are people who are in cars. And what they're doing is they're trying to flee the city because the toxic plume has been released from a tanker that spilled on the far side of the city. We're modeling how that plume spreads through space using computational fluid dynamics. And then we're modeling how people react. And their ability to escape is constrained by the physical geometry of the space and by what everyone else is doing, traffic. This being Los Angeles that we picked on at rush hour, there's an enormous traffic jam here in the middle of the city, and this doesn't go very well. But you can actually then do policy experiments in which you manipulate the space, you manipulate the road network, and you see how it might change behavior. And you can imagine now, instead of a toxic plume and people in cars, that we're interested in people walking around and seeing billboards and being exposed to food advertising and having options about where to buy tobacco or where to buy food. And this kind of spatial realism can be very important in informing those choices, and therefore having models like this can be very helpful. So what I want to stress here is this idea, this fusion of 2 important ideas. One idea is this kind of modeling that I'm showing you and the advantages it offers for getting a handle on all this complexity that's part of chronic diseases. And the second idea is the idea of a community level or a city level as a way to actually pull off and execute a systems intervention, a systems approach. And when you put those things together, that's where a lot of exciting research is happening, including a lot of research that I'm doing. So very new work that I'm doing right now that isn't published yet, but I'm telling you a bit about it, is work funded by NIH to think about these whole of community obesity prevention interventions like Shape Up Somerville, which I referred to earlier. We spent tons of money on obesity prevention in this country, but there's little systematic follow-up. And when things work, we're not quite sure why they work. Things that work in one place aren't always replicable somewhere else. And we need to understand why things that succeed, succeed, and things that fail, fail, so that we can do a better job of having appropriate interventions for appropriate contexts. And this process of implementation is very complex, and it's a process all by itself, and it's really that process that we're studying in this new project. I have many partners in crime in this project, from Harvard, Tufts, in Australia, Washington University, many different NIH, many different places. And what we're doing is trying to look at completed interventions, understand how they worked, what made them tick, and then test that knowledge with ongoing interventions. In this case, in many different contexts, in this case, a lot of work in Australia, and then use that knowledge to design brand new interventions from the ground up using these kinds of models in a very scientific way, and then put them in the field and see whether they actually work. As good scientists, that's the thing to do. And we hope to actually make a real difference by focusing on early childhood as a key window of opportunity to intervene in this space. And we're actually engaging with a large number of real communities when we do this, and we're doing participatory work with those communities to get their input, to make them stakeholders, to make them part of this process, and to sort of make sure that the science we're bringing to bear is ground truthed in important ways by what's actually going on in these communities. The other work I want to briefly talk about is work on tobacco. So it's not only about obesity here, it's about chronic disease prevention. Tobacco is still a major driver of chronic disease in this country. And the FDA, a number of years ago, was given much expanded regulatory authority over tobacco. And they are very interested in how to use that power wisely. And models play an important role in their thinking about how to do that, as evidenced by a new Institute of Medicine report which just came out today, actually, which was commissioned by the FDA and which is all about these kinds of computational models and how they can be used effectively to inform tobacco policy. And one of the models that is underway is a model we call Tobacco Town, which tries to have very realistic depictions of real communities, and not only of who lives there, but how they move around physical spaces, what those spaces look like, how it is that people go from home to work and back again, or from home to school and back again, and what paths they take, and what actually is along the way from a retail perspective. So the FDA is very interested, among other things, in so-called point-of-sale policies, which are designed to actually change the retail environment people experience. And what we want to understand is when the retail environment changes, how will people react? How will consumers react? What will they actually do differently? And is it what we hope they will do, or is it something else that would actually cause the policy to backfire? And will it work for some people but actually make disparities worse, for example, along the way, which is not something that we want. So this is part of a large network called the SCT, the State and Community Tobacco Control Network, that this work is going on under the aegis of. And as I said earlier, we're designing this as a policy laboratory to think about strategies like zoning versus licensing, strategies like drawing radiuses around schools and saying no tobacco advertising or sales can go on here. And we're interested not only in sort of what will work, but in questions that policymakers want to know, like if we do this and it works, how soon will we see it working? Can we expect results in 6 months, or do we have to wait 5 years to know whether it worked or not? Those are really important questions to a policy audience. And what unintended consequences might we have along the way? So this is work we're doing that there's some things out there that you can find about. It's in partnership with Washington University. And it looks not only at questions like overall retail density reduction, but also very targeted things like what happens when CVS no longer sells cigarettes, which they announced that they would do recently. What does that actually do? Is it a good thing? How many people does it affect? How soon will it affect them? What will people do instead of shopping for cigarettes at CVS? We need to know answers to all those questions to have a better idea of how to design effective policy in this space. So there are 4 large groups of scientists funded by the NIH working to use system science, complex systems tools, and systems approaches in a number of topic areas relevant to chronic disease prevention. I talked about MIDAS earlier. The others I want to talk about briefly is the National Collaborative on Childhood Obesity Research, which is a big umbrella organization, has a network that's using agent-based modeling to study childhood obesity and what really drives it, and to think in a very systemic way about how the biology and the physiology and the neuroscience connect with the social level and the advertising level and the built environment level in ways that are sort of unprecedented in this field. There's a network that recently concluded that's writing a book, which will come out recently, that's all about inequality and health disparities and where they come from and what some new strategies to tackle them, using a lot of this kind of systems approach and systems modeling. And there's the State and Community Tobacco Control Network that I alluded to earlier. So I'd like to stop there, thank a large number of funders who underwrote the work that you've seen here, a large number of collaborators at many institutions who are very important players in all of this, and the organizers of this talk here and other interactions that I've had around UNLV. So I'll stop there. I want to make sure that we have time, about 15 minutes, for questions, discussion. If you have follow-up questions, my email is here on this slide. Thank you very much.
Thank you, Ross, and thank you in particular for showing that Nevada doesn't rank 50th or 49th on every list. Just
That's right.
Not that we're satisfied with what he said, but it's relative. Before I ask a question, I'll throw it out to anybody who has one. Sir?
Yes, well, this is very exciting to me for the systems approach. I use systems approaches in physical science, what we call maximum entropy work, and I do a lot of that. Again, there isn't a single solution, but I noticed 3 correlations, which was quite interesting. One was that China seemed to be very low, obesity-wise, and obesity really seemed to come up starting in the 80s. And on the British study, I noticed they did have work environments and work types.
Sure.
I guess, have you seen, there certainly has been a variable since the 80s in terms of the amount of physical work and production that we're doing. We're more conservative, we're more consumer and software and other things like that. Is that an important
Well, so
vertex?
I think that's probably one among many important drivers. And what I've found in my research in this space, and what many other people have concluded as well, is that if you make a list of the things we know about the obesity epidemic, and so let's say there's 7 stylized facts about it, and you make a list of things that people have hypothesized might matter, any one of the things people think matters can explain some of the facts, but not others. And so it's very hard to find an explanation for what's going on. It's likely actually many of these things that's going on. The other thing I want to just point out is that even though the obesity rate was looking low in China, the overweight rate is much higher. And overweight is, of course, the precursor to obesity. That was actually just obesity, defined as a BMI over body mass index over 30. And the government of China is very worried about obesity as a problem. And there's some evidence, actually, that is as yet not fully conclusive, that the BMI thresholds, where risks for chronic disease start to go up, actually need to be adjusted for people from different places in the world. And that we may be sort of underestimating the likely diabetes burden, for example, shown by the current obesity rates in places like India and China. So you should take that with those numbers with a grain of salt. But great question. Yeah.
How do you, was it me?
Please.
Okay. How do you tie in the idea of the economic impact and the lack of economic access to some? When I looked at a lot of your maps, the areas that I'm familiar with, you know, you can see where economics, where the lower income, where that really lower income or largely rural, like across the entire South, you know, the Southern Belt. And Mississippi being, there was one where Mississippi was like a huge outlier. I don't know which that was. So how then do economics play a role in that? It's certainly we're thinking, and then policy. Because the first thing that I thought of was like, okay, the policies around food accessibility, availability, like SNAP, or the things that are driven mostly by lack of economics. How do you tie that in?
So economics is very important. It's a very important piece of the puzzle. But the relationship between economics and the outcome is not as simple as you might think. So it is true that the states with the highest obesity rate are also among the states that are the poorest in the nation. That's definitely true. But remember that county picture where we saw that there was huge variation even in Mississippi by county. And look at this picture for a second, which explores the relationship between gender, race, and income. And what this shows, among other things, is that income as a determinant of obesity matters more for some race-gender pairings than it does for others. So that's a really interesting finding because it suggests that whether poverty is a major driver depends on who you are and where you are in ways that are actually quite subtle. And so the more we learn about this, the more intriguing it becomes to try to actually understand what's going on. That said, there's some new evidence that just came out recently that's I find very compelling, that shows that even though it's true that childhood obesity rates have stopped growing at alarming rates on average and have sort of leveled off, that what that's actually masking is a widening disparity, and that childhood obesity rates in the bottom income quintile are skyrocketing, and those in the top income quintiles are actually falling. So it looks flat on average, but there's real disparities that are widening. So there is a lot of attention to this now because it's a major consideration and concern. Yeah. Yeah.
Has the definition of obesity remained constant over time?
Over the period of time
that
in
you're
question,
talking about?
yes. And there's a lot of argument that it actually should be amended. But
and is that
I don't wanna get into that.
globally true? Do nations?
yeah,
measure
the
it the
global
same way?
data I'm showing you uses constant
Right.
sort of metric for how it's measured. But there's a lot of debate about what the appropriate measurement actually is. And the measurement that all these graphs are based on, which is body mass index, has the virtue of being easy to calculate because it's based on your height and your weight, but actually is not the best indicator of chronic disease risk. Other things are much more closely tied to the risk, like central adiposity and body fat percentage and things that are a lot harder to measure, so we don't have so much data on them. So there's a trade-off between how good our data can be and how meaningful our data can be here that we struggle with.
Wasn't the definition of overweight dropped from a 27 BMI to a 25 BMI within the last 10 years? There was an article about that in the New York Times just this week.
I don't think that's the case.
So the
actually.
obesity at 30, I think, was constant, but the definition of overweight
Has changed. Okay. I think it must have been longer ago than that then, because a lot of the data I'm showing you
It
is...
doesn't go back to your graphs that go all the way back to 1900.
No, I didn't have
It
any...
has changed.
Yeah, okay, so those were graphs about obesity, and
Okay.
that definition has stayed very constant. The graph that has overweight on it only goes back to the 60s, and it was my understanding that the overweight definitions go back quite a bit further than 10 years, but I can look into that. That's a good question to ask.
Russ, can you give us a feel for how ABM is used to simulate and test policy interventions?
Beyond the examples I showed you of how it's used to simulate and test policy interventions in the case of infectious disease. So remember, I showed you this slide I'm trying to get to right now. That's a very good real-world example of an agent-based model that is used to test policy interventions of the kind I described in the case of flu. And here's another example of it being used to do things like evacuation planning and disaster preparedness. And the examples I showed you from tobacco, for example, is another agent-based model. And again, I talked to you about the kinds of policies it's being used to simulate. So I guess what I'm curious is what about these examples is not answering your question.
I was wondering about
Yeah.
obesity because of the kind of interventions you're thinking about.
Right.
Where to put billboards or whatever.
Right.
Doesn't strike me as...
Well, so remember the example I showed you in obesity was about these whole of community interventions. And I showed you both some of the details of how those work, and I showed you these models that are agent-based models that are being used to study exactly those kinds of obesity-specific policies at the community level. And that's really the best work I'm aware of that's going on in the obesity intervention space right now. Yeah.
Yeah, thank you for a really great presentation, sir. Welcome to Vegas.
Thanks.
I'm a systems thinker myself,
Oops.
and I'm wondering, could you talk a little bit more, I guess, maybe expand a little bit. When you have whole of community approach and you have the systems kind of integration happening, can you talk about the maybe multiplier effect and and how you determine efficacy of whatever multiplier that you're going to throw into the mix? So when you're transitioning from qualitative to quantitative.
Right.
So, and then how does timeline factor into that for, whether it's the ABM or
So we get at
whatever.
both of those questions, both how much synergy quantitatively actually goes on between different interventions and the time question of how quickly things occur. We get at both of those by focusing on mechanisms. So these are not statistical models, which are about correlations. These are detailed process representations of actual mechanisms that are going on. And when you study at that level, it answers both of those questions, because mechanisms happen at a certain speed, and they actually do specific things in a system, which you can then understand, allows you to understand how those specific things work together or differently. Just as an engineer might look at a factory floor machine and understand how different gears are working together or against each other inside the same machine. So it's about process and mechanism is how we do that. And that's not dissimilar from how systems biologists think about the process of tumor formation and how to design drugs that will interfere with that, or how a physicist thinks about processes at the particle level and designs giant supercolliders in CERN to test those theories. There's similarity in approach across those different disciplines.
What if it's left out? What if there's essential elements that are left out and it's found later, whether it's a decade later or a year later? And how?
That's always a risk.
Yeah. So how much? That must have happened several times in the past. Whatever the study was. Is there some kind of sliding scale that has been determined already of the efficacy of X, Y, Z? Having a multiplier.
So no model's perfect. George Box, who is a statistician, liked to say that all models are wrong, but some are useful. And the question is how to design a model that's useful for a particular purpose, and what to put in and what to leave out is very much a judgment call at that early design phase. But then you can test models with experiments and with data and get increasingly better models. Now, models never remove uncertainty. But they can help us manage that uncertainty. And of course, the history of medicine is replete with things that were widely believed and then turned out to be wrong. Like it used to be thought that having high cholesterol came from eating things that had lots of cholesterol in them, like eggs, and that turns out to not be true at all. We now know. But there are lots of examples like that. But a lot of those things that you can point to came from correlational evidence and not from a detailed understanding of the mechanisms, and was actually an understanding of the mechanisms that led to the discovery of the right answer. So I think in general, that's going to be maybe a more promising path to avoid the kind of pitfalls you're talking about, but of course it's far from perfect, as most things are. And it's certainly not easy.
Can I ask a really quick one? Do you think the next 20 years is going to be more reductionistic trending or more interactive, interdisciplinary trending?
Well, I think there will be forces pushing in both directions. Tradition will push us toward self-reinforcing reductionism, but I think the problem space we are confronting as a society, a global society, is inevitably going to push us to thinking about interaction and more systemic approaches and more interdisciplinary approaches, because these are just not problems that you can solve very well from a single perspective, in my view.
Could I ask Ross?
Yeah.
The city that was ground zero for the recession, both economically and otherwise,
Yes.
is that time period going to be an aberration and have exacerbated some of these issues, or do we have to recover from that?
Yeah, I mean, I'm sure it had an effect, and you can actually argue it either way. You will find people who argue that the recession is actually why we might see temporary slowing of obesity growth, because people had less money to spend on food and they ate less food, which is actually helpful in many cases when you're trying to combat obesity. And you'll see other people argue that the recession actually worsened disparities, which worsened access to healthy alternatives, which actually worsened obesity in many cases. And I think maybe both could even be true at once, radical thought. So it's not clear what the net effect was, but I'm sure it had an effect.
And maybe our audience will know, but you showed some very interesting Nevada and Las Vegas specific data. Are we getting better? Are we getting worse?
I think you are getting better since the last time I gave this talk, a similar version of these statistics here, which was a couple of years ago, as you know. So.
Oh, I'm sorry. Yes, please.
What if we try a completely different approach and eliminated bankruptcy for medical costs? In other words, we're going to the people and saying, oh, look, it's not fair for you to choose all the bad decisions and then expect government to go tax or steal money from people that don't do the bad behavior. And therefore, when their bankruptcy starts showing up and their bills start showing up, then we shut down their freedoms. They can't go to a professional sports event. They can't buy a new car.
That's not something I've studied, so I can't really comment on that. Thanks.
Okay, great. Thank you all very much. Appreciate your time.
Thanks.
Thank you, Rob. We'll be back in 2 weeks. We won't be here next week because of spring break, but we'll be turning to the American presidency and military intervention. We'll have Jeremy Shapiro out to give us a global perspective on that. Hope you can join us.
Russ, I'll
Yeah.
stop by about